Good afternoon, everyone, and welcome to the webinar. My name is Lori Brannon. I'm with the Illinois Department on Aging. Before we get started, I want to make sure everyone can hear me. By using your chat room, please type in that you can hear us, and then we'll move forward. Everybody in the audience is in listen-only mode. Okay, great. Thank you. All right, people can hear us. Great. Again, thank you for joining us today. We do have a guest speaker from SIU School of Medicine who's going to introduce herself. If at any time you do have a question, please use the chat room to ask your question, and we will get to those questions when we have a moment to pause. Are you going to do these at the end, you think, Cindy?
Well, let's do them at the end.
We'll do them at the end. Okay. All right. So I will let Cindy introduce herself, and then we will begin.
Good afternoon, everyone. This is Cindy Womack. I'm a nurse practitioner with SIU School of Medicine, Neuroscience Institute, Center for Alzheimer's Disease and Related Disorders in Springfield, Illinois. Today we're going to talk about living alone with dementia, a role for technology. If you joined us last year, this presentation today, the first half of it will be pretty much a review of what we did last year, but we're going to expand on the role for technology today. I have nothing to disclose. The proprietary names that I will be using in this presentation are for the purpose of examples, and they're not intended to serve as a product or company endorsement. I want to make that clear before we get started. Our learning objectives today are to describe the risks faced by community-dwelling people with dementia who live alone, describe a model for balancing risk in people with dementia who live alone, and then describe two types of technology that can support independence and safety in community-dwelling people with dementia. Approximately 29% of Americans aged 65 and older live alone. This is based on a 2011 U.S. Census Bureau data. An estimated 58% of older adults with dementia are community dwelling. Of those living in the community, an estimated 75% live with another person. Approximately 25% of community dwelling older adults with dementia live alone. Various studies estimate somewhere between 20 to 35% of older adults with dementia live alone. So this is not a hard and fast number, but what we can see is that there are large numbers of people with dementia who live alone. In the 2008 Medicare current beneficiary survey, they found that about 25% of Medicare beneficiaries with dementia live alone. So therefore, we have large numbers of older adults with dementia who live alone in the community, and they face risks to their health, their well-being, safety, and independence while they are community dwelling. Too frequently, the needs of these individuals are unmet or even unknown to family, friends, and service providers until a crisis arises. Individuals with a diagnosis of possible dementia are more likely to be living alone compared to individuals with a diagnosis of probable dementia. Those with possible dementia diagnosis are typically more highly functioning and do not meet the diagnostic criteria for probable dementia. When we consider all Americans aged 65 and older on average, they are likely to be older females who live in poverty. They are likely to be less impaired and are more able to perform activities of daily living. Older adult women of non-Hispanic, white, and African American ethnicity are more likely to live alone, as are African American men. And this demographic includes many with dementia. In one study from Edwards in 2007, in a particular region of the United States, as many as 52% of community-dwelling African Americans with probable Alzheimer's disease lived alone. So these are people that are more impaired than what we found in other studies. So the presence of cognitive impairment or dementia should not eliminate the option of an older adult living alone. However, Safely living alone optimizes the health, well-being, and independence of people with dementia. So what is a risk? So simply stated, a risk is an exposure or situation that subjects someone or something to a possible harm, danger, or loss. It's important that we understand the risks that people with dementia who live alone face so that we can help them maintain their independence and their safety. Many factors influence risk for cognitively impaired individuals. Some of those factors are intrinsic to the individual, while others are extrinsic, arising from the environment and support networks. Intrinsic factors include physiological effects of dementia on the individual's cognitive function, such as memory loss, impaired language, impaired insight, judgment, and problem solving. Individuals with dementia may not recognize their cognitive impairment or the implications of such impairments. They may reject offers of assistance, demonstrate poor planning and problem solving. Resistance to change is another factor. Psychological or personality traits influence risk. Many older adults value their independence over safety. They have a strong preference for living at home that can emanate from the ideals of self-determination, freedom, and independence. For some, realization of the American dream is measured by home ownership, having independence and freedom to drive where you want, when you want to. Older adults can view the use of services or alternate living arrangements as a loss of their self-determination, independence, and freedom. The positivity bias is another factor. This is a tendency for older adults to prefer positive information over negative information when compared to younger people. This bias can influence information processing and decision-making in older adults. So when presented with warnings about risks, the older adult may focus on more positively associated information while neglecting or disregarding negative information. Health literacy and numeracy can certainly affect the ability to comprehend, can also be a factor influencing risk for this population. Health literacy is the ability to access or acquire, process, understand, and use health-related information and services. Numeracy is the ability to access, process, understand, and use mathematical information and/or ideas. Interestingly, in everyday life, people generally rely on hope, intuition, feelings, past experience, and/or trust in decision-making regarding risk and uncertainty. Very few people base their risk decisions on concrete measurements of risk. I'll just think about that for a minute. You know, how many of us have purchased a ticket for Mega Millions this weekend or Powerball? To put this in perspective, the population of the United States is 325.7 million. The odds are 1 in 302,575,350 to win the Mega Millions tonight. Your odds of being struck by lightning at any time during a year is 1 in 1,171,000. So our odds of being struck by lightning are the odds of winning the Mega Millions is much greater than our risk of being struck by lightning. That is, we're more likely to be struck by lightning than win the Mega Millions tonight. But I'll bet many of us who are tuned into this presentation today have already got our tickets. So good luck. I hope one of you are the winners. So anyway, when we think about health literacy and numeracy, as providers and professionals, we have a duty to ensure that those that we serve understand and can assimilate information for their personal health-related decision-making. You know, it's important to assess an individual's literacy level and ensure that all of our communication, verbal and written, is congruent with the individual's literacy level, especially when we are communicating risk information and risk reduction strategies. Another factor that can affect risk is the availability of formal or informal support networks. Lack of an informal or formal support network increases risk by delaying identification of cognitive impairment, It enhances isolation of the older adult and delays the acquisition of formal health care and/or social services. Informal support is any form of care provided by non-paid family and friends that includes everything from safety checks to direct personal care. Studies have estimated that 1/3 to 1/2 of community dwelling elders living alone with dementia do not have a caregiver. Self-neglect is another type of risk. Self-neglect can present as a decline in personal hygiene, that is, a person who decreases the frequency of bathing or starts taking sponge baths, refuses to bathe altogether, demonstrates unkempt grooming. For men, this might present as not shaving or visiting a barber. For women, they may cease to use makeup or get their hair done. Individuals may wear the same clothes every day despite the presence of debris on the clothing. They may wear clothing that is inappropriate for the season or worn out. Clothing may also signal self-neglect. Individuals may lose weight due to an inability to secure, purchase, shop for, or prepare adequate meals. There may be an increase in convenience foods that require little or no preparations. So in the home, you may see, a lot of cookies, boxed breakfast cereals, ice cream, fresh fruits or vegetables, and people may not be eating well-balanced meals. These individuals are also at risk for developing certain vitamin and nutrient deficiencies, such as B12, electrolyte, protein imbalance, and we all know that dehydration is also a concern. Self-neglect in people with dementia who live alone is associated with an increased need for emergency medical services because people may neglect monitoring of their health, or they may not follow treatment plans for chronic disease, such as not taking medications as prescribed, antihypertensives, or particularly medications for diabetes. In one study conducted by the Chicago Health and Aging Project, the prevalence of self-neglect was found to be 16.6% for a group of 9,318 adults over the age of 65. The mean age of this group was 74, and there were substantial differences in self-neglect between ethnic groups. For Caucasians, self-neglect in this group was 5.3%, and it was 21.7% for African Americans in the study. Interestingly, for the Chinese older adults in Chicago, the prevalence of self-neglect was 2.11%. Social isolation and loneliness are other types of risk factors. Cognitively impaired individuals tend to withdraw from their usual social situations over time. That could be work, volunteer activities, or religious group participation. This further increases the social isolation. So socialization is one way that we build and maintain these informal support networks. There are many types of safety risk factors. Family and professionals tend to prioritize an individual's safety over autonomy and independence, but the older adult will often prioritize in the reverse fashion. They prefer their autonomy and independence over personal safety. So safety risk factors can be medication non-adherence. This is a significant problem in older adults, leading to increased medical office visits, emergency department visits, and hospitalizations. Driving. Older drivers with dementia are 2.5 to 4.7 times more likely than healthy age-matched controls to be involved in a motor vehicle accident. Older drivers are more easily injured and likely to have accident-related medical complications and die from those complications. Falls. Everyone who works with older adults knows or should know that falls are a leading cause of morbidity and mortality in older adults. The risk of falls increase with age. Financial fraud is a significant risk for cognitively impaired older adults living alone, and this is known to be underreported. Wandering. Even in the early stages of dementia, an individual may wander away from home or wander while driving. It may be an extension of restlessness or pacing, or that the individual is looking for someone or something and their surroundings are unfamiliar. The behavior can be goal-directed in that the individual may want to go to work or is looking for their home. This next slide is a depiction of the web of causation model. I think models help us frame the problem and help guide our thinking in the way that we address problems. I like using this model to illustrate the complexities associated with concepts such as the person with dementia living alone. We can see the interrelatedness of the factors, also known as the determinants of health, and get a sense of their contribution to the outcomes. I've simplified this model to make it easier to view on the slide, but as you study the model, you might imagine that impaired cognition, can I see my arrow? Okay. You might see that impaired cognition, physical mental health, or any of the other factors in the blue boxes here can be directly interrelated to each other. So impaired cognition can affect their physical mental health, can also influence resistance to change or assistance. Likewise, health literacy, numeracy, positivity bias can also affect the other factors. So it's really, these are all interconnected with each other. So, as an example, an individual with impaired cognition may hold unrealistic positivity bias, coupled with reduced health literacy or numeracy, and may not understand the risks or importance of medications for the treatment of chronic disease. So they may not take, like, their blood pressure medicine because they're feeling lightheaded or dizzy. Or they may take too much of it and end up with increased dizziness, which could lead to a fall or fractured hip or even institutionalization. So all of these things contribute to the risks. We see, major risks of self-neglect, safety, social isolation, but we also have other risks: medication non-adherence, falls, driving risk, financial. All of these can contribute to unmet needs for the patient. If we don't address these, it could lead to a crisis and then institutionalization or increased morbidity or even death in the individual. So I want to briefly review a few common safety risks. This is an overview and not an exhaustive list of safety risks for the individual living alone. Medication non-adherence is a significant problem in older adults. Adherence to medications is simply taking the medication as prescribed by the provider, that is the correct dose at the correct time by the correct route. An estimated 50% of older adults are managing 5 or more medications. The consequences of non-adherence include poor drug efficacy, leading to inadequate disease control, increased hospitalization, disability, and early death. There have been studies, and in one study from 2005, Yee and their group estimated that 19% of emergency department drug-related visits were due to non-adherence. Non-adherence in the cognitively impaired population is nearly 3 times that of the cognitively intact population. Many factors affect medication adherence, such as patient health literacy, cognitive function, the complexity of the medication regimen, the cost, the presence of adverse effects, and even the relationship between the patient and the provider. If that patient does not trust the provider, they're less likely to follow the medication regimen. Non-adherence can also increase the risk of adverse drug events, that is, an event resulting in injury to the patient. We all have seen this with people who, take too little or too much Coumadin, maybe too much, too little blood pressure medicine. If they don't take their blood pressure medication, blood pressure rises. If they take too much, maybe they become dehydrated, dizzy, lightheaded, and have a fall. Older adults are vulnerable to adverse drug events due to physiological changes that alter the drug absorption, metabolism, and excretion. Also, things like polypharmacy and cognitive decline also influence adverse drug events. National surveillance data indicates that older adults have a 7-fold risk increase of needing hospitalization because of adverse drug events. Driving, the Insurance Institute for Highway Safety reports that older drivers have higher fatal crash rates per miles driven than any other group other than young drivers. 18% of those killed in traffic crashes in 2015 were age 65 and older, according to the National Highway Safety Administration. Cognitive, visual, and motor impairments are responsible for older drivers' higher crash rates, according to the Governor's Highway Safety Commission. Also, I want to mention that getting lost while driving can be a serious problem for cognitively impaired older adults living alone. Getting lost can cause significant psychological distress for the older adult and increases their risk of institutionalization. In a study published in 2016 by Pai and Lee, they defined getting lost as having an event occur in a familiar environment. The older adult had the perception of having trouble reaching their destination or home. They sensed that they were being lost and they required assistance of others to reach their destination, and the trip was goal directed. That is, they were not just wandering, they were really trying to get somewhere but couldn't. Nearly 30% of community dwelling adults age 65 and older will have a fall. The Centers for Disease Control report that the direct medical cost for falls is $31 billion a year. This was in a 2017 report. More importantly, falls present a serious threat to cognitively impaired older adults and increase the risk of institutionalization. Fraud can be committed by a trusted family member, friend, via the internet, door-to-door salesman, repairman, or over the phone. Estimates of financial loss due to fraud is $2.9 billion for older adults, and this was in the 2011 MetLife study. The loss can be devastating as older adults, particularly those with cognitive impairment, have limited options and time to recover these losses. In addition, this type of fraud can create significant psychological distress and loss of independence. So now, we know what some of the major risks are for this population. So I want to review the acceptable and unacceptable model of risk that was developed by Cotton Tierney, because I think, again, having a model to follow will kind of help us put this problem into perspective. So the Cotton Tierney model describes a process occurring between family members and the cognitively impaired older adult, but I think it's also useful for professionals working with people with dementia who live alone. In essence, this model describes a process in which family members' initial perspective of the cognitively impaired older adult living alone with an acceptable level of risk. When family members notice red flags, their perception changed to one of an unacceptable level of risk. Family members then engaged in risk balancing strategies so that they could regain a perceived acceptable level of risk for the cognitively impaired older adult who lives alone. So acceptable risks, this represents a steady state of risk. Each of us face and adapt to certain risks every day. We live in a steady state of acceptable risk. For example, driving to work carries a certain amount of risk, but we wear our seat belts, we avoid using cell phones while driving, and we observe the speed limit to mitigate the risks to an acceptable level. Older adults learn to mitigate their risks when faced with two major life changes, such as living alone after the death of a spouse or learning to live with the effects of their own aging. As the older adult accommodates for these changes, such as learning how to manage their finances or adapt to physical age-related changes, families tend to perceive an acceptable level of risk. So we see, the older adult, they may drive at a little later in the day after rush hour traffic. They drive slower, they allow more distance between themselves and the car in front of them. These are examples of how they adapt to these age-related changes. Our physical abilities, because our physical abilities do change with age, and it takes longer to perform certain tasks. But that doesn't necessarily increase our risk of harm. And that's the same for the older adults that we serve too. Red flags are warning signs. Red flags include situations such as losing weight, not much food in the refrigerator, not leaving the home as frequently, wearing the same clothes for several days, or withdrawing from social activities. Red flags may include poor medication adherence, missing health-related appointments, not paying bills, or a myriad of other problems. In this model, red flags are heralded by changes in a family member's perception of a change in risk to the older adult. That may be an obvious warning sign, such as wandering outside at night. Major lifestyle changes may precipitate the perception of a red flag, such as the death of a spouse or a fall with an injury. Unacceptable risks are changed perceptions or a redefinition of risk prompted by red flags. So in this model, family members evaluate red flags and decide that the risk has changed to an unacceptable level. Unacceptable risk often emanates from issues such as falls, driving, medication, meal preparation, and diet. Risk balancing strategies typically begin with increased family surveillance and modifications to the environment and/or older adults' routine. Increased surveillance can take the form of daily phone calls or increased visits to the home. Environmental modifications include installing grab bars, removing trip hazards, installing toaster ovens or microwaves, and disabling gas stoves. Routine modifications might include having medications set up in a pill box, automatic bill paying banking, home delivered meals, or the use of in-home care services. This slide is a graphical representation of the Cotton-Tierney model of risk. And I think that this is a good model because I think we, as professionals, we can use this model too as we work with an older population, and particularly those with cognitive impairment. So, as an example, if we look at medication non-adherence for someone taking blood pressure medications, diuretics, or an anticoagulant. So red flags might be an increase in blood pressure, weight gain, shortness of breath, or an ER visit for, let's say signs of gastrointestinal bleeding. Unacceptable risk would be taking medication from the prescription bottle without closer monitoring. So, maybe the individual is taking medication out, but perhaps they forgot, and maybe they're going back and taking the same medication again an hour later. So a risk balancing strategy would be to use unit dose medications, an automatic medication dispenser, or having family or paid caregivers set up medications weekly and monitor them. Maybe weighing the patient weekly, monitoring their blood pressure, telephone reminders, or even transportation for lab monitoring of the anticoagulants. The risk balancing strategies would allow the individual to continue living alone with an acceptable level of risk. So, in summary, I think that the process that families use, as described by Cotton-Tierney, is also a process that professionals often use. We often negotiate risk balancing strategies with the older adult, but many times are not able to intervene unfortunately, until a crisis arises. So how do we assess risk and unmet needs? Well, there's 4 broad domains: cognitive and mental health, self-care capabilities, home safety, and I always like to add the ability to respond to emergencies in disasters. We're going to walk through each of these broad domains for assessing risk and unmet needs and identify appropriate services. The first domain is cognitive impairment and mental health. In this area, cognitive impairment, depression, anxiety, social isolation are risks for unmet needs that we should assess. So what do? We need to ask some questions. Is there an actual cognitive impairment? How severe is it? Which functions are affected? Is it memory, language, insight, judgment, problem solving? Is the situation complicated by depression or anxiety? Does the patient have a history of mental health issues? You know, have they developed a cognitive impairment that is superimposed on top of long-standing bipolar disease? And then we need to, you know, ask, do they have family or friends? What is their support network? How often do they visit, and to what degree could they help the older adult? And then that helps us to determine what type of services that we can recommend or help institute that would address the risks and the unmet needs for this older adult. Services are highly individualized, but for cognitive and mental health, it needs to start with an accurate diagnosis and treatment if indicated. Identification of social networks and development of a social network if that network is insufficient. So we might recommend things like transportation, home delivered meals, friendly visits. You know, the list could go on and on depending on the person who has the cognitive impairment. We also want to look at self-care capabilities. Cognitive impairment is a risk for unmet self-care capabilities. So are physical limitations and chronic disease and limited financial resources. All of these contribute to risk and unmet needs in the realm of self-care capabilities. So again, our assessment questions, we need to ask if there is an actual cognitive impairment. If so, how does it affect the person's ability to perform the ADLs? Are they forgetting to prepare a meal? Are they forgetting to eat? How severe is the impairment? What are the functions affected? Is it memory, language, insight, judgment, problem solving? What are their physical limitations? Are they experiencing shortness of breath? Are they unsteady when they're walking, having frequent falls? Is this playing a role in their ability to get a bath? Can they safely walk around their home? Can they get in and out of bed to and from the bathroom safely? Can they get in and out of the home in an emergency? Are they able to afford their medications? Do they have safety devices? All of these things and many more we need to think about when we're assessing someone's self-care capabilities. And the services we might recommend could be in-home community-based services like a paid caregiver, someone to come in and assist with chores. Maybe they need walkers, new glasses, hearing aids. Maybe they need physical or occupational therapy, meal programs, transportation, or medication reminders and monitoring. Home safety. Again, cognitive impairment plays a role in home safety because people with cognitive impairment often can have visual spatial deficits. There may be fall hazards. They may be having falls wandering out of the home. They may have a physical and financial inability increased risk of unmet home safety needs. So our questions then are, is there actual cognitive impairment? Again, how severe is it? Is there a gas or electric stove in the home? Are they using a fireplace or oil lamps or candles in emergencies? I have to say, I have been in the home of an older adult when the power went out during an ice storm, and she had about 60 candles lit, open flame candles lit, scattered all over her living room and dining room because she didn't have anything else to use for light. And that was, that was a real big red flag to me. We also need to make sure and check for trip hazards in the home. You know, can they get in and out of the home safely? And can they use the bathroom safely? And sometimes we need to find out, do they even recognize their home? Or are they wandering out of their home? Do they have smoke detectors or carbon monoxide alarms? And a lot of times, services could include things like home safety checks. In smaller communities, law enforcement will make these home safety security checks. In larger communities, you can usually get law enforcement to come out to do a home security check. Security companies will also do this. We may need to do fall risk assessments. Maybe that person needs to go to PTOT, have an exercise program. Maybe we need to put alarms or smart home devices in there, or find community repair services. You know, maybe we need to find somebody who can put a ramp at in their front door to get in and out of the home a little easier. Cognitive impairment can also hamper the individual's ability to recognize and respond to emergencies. We don't always give enough thought and preparation in thinking about emergencies and disasters for people with dementia who live alone. You know, when I see like these hurricanes hit Florida and the Carolinas, you know, I worry about, or not worry, but I wonder about the preparation for people with cognitive impairment, mild cognitive impairment, or early dementia who are still living home alone. And I wonder, you know, how prepared they are, and were they, you know, who's helping them get ready for these type of emergencies. So again, in assessing this risk, we need to think about what the most likely emergencies are: fire, flood, tornado, extended loss of electrical service like from an ice storm. And how is this individual going to meet their basic needs? Is there a plan for sheltering in place, or a plan for sheltering out of the home safely, like going to another family member's home? Is there an emergency kit? Is it maintained and checked regularly? Do they have emergency food, water, and heating? And then the services, again, include establishing an emergency plan and access to communication devices or emergency response devices, safety calls or visits, whatever we need to do to keep that person in their home safely. What tools do we have that can help with this? Well, this slide lists common objective tools to help you measure cognition, mental health, and decisional capacity. I'm not going to go into each one of these in detail. They're on your handouts. I think each organization needs to evaluate and choose the appropriate tool for their clientele and their workflow. I just want you to know that there are many tools out there that can help you make in your assessment of this older adult. There's also, you know, the Lawton and Brody physical self-maintenance scale, scales to measure activities of daily living, fall risk, home safety. Right now, the FRADUP, the Fall Risk Assessment Tool, is a free web-based tool, but I would expect they're going to be charging a fee for that in the near future. The timed up and go test, really easy to do in a visit, to let you know, they measure the fall risk for an older adult. And then occupational therapy will often, if they're involved in the care, or if you have home health, you can frequently get occupational therapy to make a home visit and do a home safety evaluation, which can be very beneficial. I want to say a few words about a couple other, let me go back here to the, talk a little bit about this assessment tool that Lisa Gweither developed. This is a questionnaire that Gweither and Ballard developed, and it's basically uses objective observations of the individual rather than the individual self-report. So some questions may not be applicable to the specific situation, but it's something that you can consider using, and it's very easy. I've given you the reference there. You could look it up and use that tool. There's also an assessment tool that was developed by the University of Iowa, People with Dementia Living Alone Risk Assessment. And on this tool, the tool creates 4 categories of risk: emergent, emergent, semi-emergent, semi-emergent, and non-emergent. And scoring is based on the number of conditions per category. For example, an individual only needs 1 condition in the emergent category to indicate immediate help or placement is required. And that could be something like hallucinations, delusions, aggression, or suicidal ideation. And 1 condition might be sufficient in the emergent, semi-emergent category, depending on the individual circumstances. And then as you progress down to the semi-emergent, you need 2 risks in that category and 3 in the non-emergent category. So this is a graded measurement of risk. And I want to say a few words about a couple of other concepts that we need to consider and that should guide our work with the individual with dementia who lives alone. First is that our work frequently centers on balancing autonomy and safety. In order to balance the autonomy and safety, we need to consider the decisional capacity of the individual. There are 4 requirements of decisional capacity: communication, understanding, appreciation, and reasoning. Communication, this requirement is satisfied when the individual reliably communicates their choice. Communication can be verbal, in writing, use of a communication board. And so we would ask that person, have you decided on a service? Can you tell me what your care decision is? Frequent reversals of decisions may indicate a lack of capacity, so kind of be on guard, because frequent reversals of decisions could be a red flag. Understanding is the individual's grasp of the fundamental meaning of the information. So a person who demonstrates understanding is able to paraphrase the information, particularly the nature of the situation, the purpose and nature of the services, alternatives, and benefits and risks of harm. Appreciation is the individual's acknowledgement of their situation and the likely consequences. Questions we might ask are, what risks do you see for living alone? Do you believe you need assistance? What do you believe will happen if you accept the services? What do you believe will happen if you reject the services? Reasoning is the individual's engagement in a rational process of manipulating the information provided to them. The focus is on the process of reasoning, not on the outcome. You know, we have to remember that even people with early cognitive impairment may have decisional capacity, and they have a right to make decisions, including those we don't agree with or that to us might seem unreasonable. We need to recognize that decisional capacity is dynamic, it fluctuates, and it's also can be issue specific. They may have decisional capacity for deciding, what their daily routine is, what clothes they want to wear, but they may not have decisional capacity to determine if they should be driving or not. The other concept, the second concept I just want to touch on, because I think it's important to think of these things as we work with this population, is person-centered service or patient-centered care. So what this is authentic collaboration with the individual. That is, what matters to this person we're trying to help. It's rooted in respect for the individual, responsiveness to the individual's values, preferences, and needs from their perspective. The individual is involved in their care and fully collaborates in their care. So this is making them a partner in their care. It's not like we're going to come out and we're going to put all these services in places for them and take care of them. We really need their participation. They're a partner in this process. This involves relationship building between the individual and the service provider. It's based in honesty, integrity, and trust, and it requires empathetic listening to that individual with dementia who lives alone. So in supporting the autonomy and safety, it's helpful that we identify, communicate, and coordinate with stakeholders. As we do this, we need to be cognizant that the individual with dementia living alone is our primary concern. We do not elevate the choices of family, friends, or even other professional service providers over the needs of the individual. So, from my perspective as a nurse practitioner in an outpatient setting, it helps me to know the services and concerns of others involved in the care of the person with dementia. If there's a home care worker who knows that this patient's not taking the medication that I prescribed, I would welcome having that knowledge, because it tells me that I need to discuss this matter with the patient. On the flip side, if a caregiver comes into the clinic and says, oh, this person shouldn't be driving, or they shouldn't be living alone, well, I kind of need to put the brakes on that and get the patient's perspective. Not that I would disregard that information altogether, but there may be other factors involved. Maybe this person is very challenging and that home care worker's burnt out and having a hard time managing the behaviors. So I really need to evaluate that thoroughly. But it is important to communicate and coordinate with stakeholders. So again, in supporting autonomy and safety as professionals, we're taught or we learn with experience to recognize the red flags that indicate unmet needs. I've listed some common red flags on the next two slides, but realize this list is just a sample and it's not exhaustive of all the possible red flags. So declining cognition, social isolation, weight loss, all of the things on the next two slides. Each professional is going to have a different situational perspective of the individual with dementia who lives alone. However, we all need to recognize red flags. The red flags might be specific to our practice. I'm unlikely to be aware if an individual is paying for unnecessary home repairs, or if they forgot to pay their tax bill, or their utilities are about to be shut off for lack of payment. Whereas in your work, you might recognize that more than I would. Again, using a patient-centered approach, we should discuss red flag concerns and facilitate the development of a care plan. I might say to the patient, I'm concerned about your weight loss. I'm wondering if you're eating like you should. What are your thoughts about this? Much of our work involves negotiation with the community dwelling person with dementia. And we have to discover what services they're willing to accept to reduce risk while ensuring their independence and safety when they're living home alone. So that brings us into risk reduction technology. So the question before us is, how can technology reduce the risk of the population we serve? As we learned at the beginning of this presentation, those living alone are more likely to have a diagnosis of possible dementia. They may have mild cognitive impairment, which increases risk for dementia or even an early dementia. But overall, they're generally higher functioning adults. Technology can be useful for those who live alone because it can allow for increased monitoring to identify red flags. Home safety, such as, if they're leaving the stove on, wandering, particularly wandering out of the house at night, driving, when are they driving, where are they driving, are they getting lost, are they driving at night when they have a night restriction on their license. It can help us monitor medication compliance, blood pressure, weight. You can even monitor your own EKGs now. Technology can also help us connect the person with dementia with assistance. Emergency response buttons have been the gold standard for years, but they only worked within an approximate 1,500 feet of the base station. You activated the button and that activated the base station, the receiver that initiated a call to a call center. Newer models can use cellular and GPS technology, which extends the range. Technology can also help us support memory function with things like appointment medication reminders, cognitive exercises in the form of memory games. It can also help support activities of daily living, particularly instrumental ones, by increasing access for shopping, transportation, meals, entertainment, and even there are now some apps and programs for financial tasks. So I want to look a little closely at connectivity because, I hear, well, older adults don't use technology. Well, yes and no. Let's look at technology first. That's a broad term, and for this presentation, I'm specifically referring to the use of computers, handhelds, smart devices, and applications. So it's pretty broad. Connectivity for this presentation refers to the use of a desktop, laptop, handheld, and internet. So this is data from the United States Census Bureau's American Community Survey from 2015. I want you to look at this. In 1984, 8% of households in the United States had a computer. I have to say, my house was one of those that had a computer. If you look at the 2015 survey, In the age range from 35 to 45, 94.4% of homeowners had some type of device in their home, and that would be a desktop, laptop, or handheld. And for people age 65 and older, 70.9% had a device. So, you know, the use of technology does decrease with increasing age, but I think as people become more familiar with the technology and the technology becomes more affordable and accessible, and as the cohort ages out, we're going to see higher percentages of technology use. And if we, looking at handheld devices, that's like your smartphone, 89% of people aged 35 to 44 had a smartphone in 2015. For people over 65, 47.1%. So that's almost half the people age 65 or older in 2015 had a handheld device. Demographics can affect the use of technology and connectivity. Studies, Ryan and Lewis did who prepared the Census Bureau's American Community Survey report, found that when you look at the demographics, Hispanics and African Americans are more likely to rely on a handheld device for computer services. Like Black non-Hispanics who had handhelds were 70.3% versus 65% of them having a desktop or a laptop. As far as handhelds for Hispanics, 75.8% had a handheld versus only 68.3% for desktop, laptop. Low income are less likely to use a desktop, laptop, or handheld device. This is pretty striking. If you look at annual household income, less than $25,000, 51.8% had a handheld, 52.5% had a desktop or laptop, 51.7% had internet access, 51% had broadband access. If you just skip ahead to annual household income of 50 to 99%, 82% of those had handhelds. Now remember, that's compared to 51.8% of people with an annual household income less than $25,000. 85.6% of people with household incomes of $50,000 to $99,000 had broadband internet access, compared to 51% of those with 25 or less. Computer and internet use is highest in metropolitan versus non-metropolitan geographical areas. A little harder to access broadband out in the rural areas. Education and the presence of children also influence use. If there are children under the age of 18, the use of desktop, laptops, handhelds, and broadband increases. This is probably because much of this is now being required for education in the children's education. If we look at the user's education, individuals with less than a high school degree or diploma, only 46.2% had a desktop or laptop in their home. Only 47.9% of them had broadband access. If you compare that to people with a bachelor's or higher degree, that number jumps to 93.7% who have desktop laptops, and 91% use broadband, and 87.4% had a handheld device, compared to 50.4% of people with less than a high school diploma. So we really need to think about how this data informs our assessment and potential barriers when recommending technology for the use of older adults who are cognitively impaired and living home alone. Bengi and their group, in their 2018 report of their research, what they did is they used a convenient sample of 100 patients or caregivers who were referred for neuropsychological evaluation to obtain self-reported utilization of smartphones. So they were wanting to know about the people they see in their practice, how many of them are using a smartphone. And what they found are that patients were less likely to own a smartphone. Increasing age was associated with less use. The patients primarily use the smart device, smartphone, for email, internet use, and probably to check Facebook. Their use of reminders and calendar tools, they use less often, monthly to weekly, whereas the other they use weekly to daily. So patients do use smart devices for social email and internet more often than using it for actual tools like calendars and reminders, but there's good numbers of them using them, so we need to pay attention to that. They also found that those who were referred for geriatric cognitive disorders were less likely to own or use the smartphones, but 55% of caregivers reported using a smartphone in caring for the patient. So, more than half of caregivers are using these devices to help them in caregiving. Brown and group looked at the use of smartphone technology to support Alzheimer's dementia caregivers. This is from a 2017 published study. So what the researchers did is they searched Google Play, Apple's App Store, internet blogs, articles, organizational websites, and they're looking for apps that caregivers would use. They initially found 29. They had to exclude 8 because 7 were no longer available and 1 app was not available on a smartphone. And that left them with 21 apps. They excluded 8 from that 21 because those apps were not focused on dementia. Ultimately, they found 13 apps that were focused on helping support Alzheimer's, caregivers of people with Alzheimer's dementia. So most of the smartphone applications were designed to monitor people with dementia, their location and their activities, or have reminding type applications. So, what does this mean for us? The apps available, they were acceptable in quality, but their engagement ratings ranged from poor to acceptable. So apps that are less likely to be used if they do not engage the caregiver, the user. So that's an important thing to consider. There's also a lack of culturally competent apps. Alzheimer's disease apps need to be integrated into clinical care. We need to embed reliable, validated tools into the apps to help clinicians with decision making. Apps need to support varying levels of literacy and computer mastery. And also funding for smartphones limit their use. They're pretty expensive devices. In another study, this is a 2014 published study by Harton et al. They designed a technology adoption and usage tool, and they designed it to provide 3 core functions. They wanted the tool to give assistive reminders, to collect data on whether that reminder was acknowledged, missed, or if it was missed because the device was powered off. And they also collected sensor platform data from the device. That's from the internal accelerometer, gyroscope, and proximity sensors embedded in the device. And so what they found was that 58.1% rate of acknowledgement of the reminder. So the device gave a reminder to the person with dementia to, complete an activity of daily living, such as eat a meal, drink, take a medication, or a reminder for an appointment. So either the person with dementia or their caregiver had to acknowledge the reminder, and that occurred in 58.1% of the reminders that were sent out. The mean response time for the acknowledgement was 26.4 seconds. 22% of missed reminders were due because people turned the device off. So this was a small study, so I don't think we can really generalize much, but I think it lays the groundwork telling us that we really don't know a lot about how these devices are used in the population, either by the patients or the individual with cognitive impairment or their caregivers. So we need to take a deeper look at this and figure out what we can do to help them use these devices. So next we're going to look at some specific technology. Virtual assistants are essentially software that allows a user to interact with a device via voice commands. The software is integrated into various objects or platforms such as speakers, smartphones, TVs, appliances, cars, smart clothing, watches, websites. You may see synonyms for them such as digital assistant, personal digital assistant, voice assistant. They're all over the place now, and this seems to be growing every day. On the next couple of slides, I've listed 4 of the best known and or used virtual assistants. I'm not going to give a comparison of features between those listed because this is really beyond the scope of this presentation. So I just want you to be aware of what they are. I've given you the links so that you could look these up and compare the features. I also want to emphasize I'm not endorsing any product or service in this presentation. In fact, the products listed on the slides was determined by the size and readability of the website link. So, Apple, Google, Microsoft, Amazon, they all have virtual assistants. So what can virtual assistants do, or how can they help that person with cognitive impairment or dementia who lives alone? Well, you can set alarms and reminders. You can put voice commands in and ask it to let you know every day at 8 o'clock when you need to take your medications. You can put appointments, reminders in there. They can be used to contact others in an emergency. You can get text, short message service or phone calls. You can make them in an emergency. You can use these devices and software to make lists, such as shopping lists, to-do lists. You can get the latest news and weather. You can use them for entertainment, to play music, videos, movie. You can read audiobooks on them. They can adjust your home lighting, your thermostat. You can place food orders, to certain restaurants. You have a favorite restaurant, you could use one of these virtual assistants to, order your spaghetti and meatballs from the Olive Garden. You can look up recipes, get cooking instructions. If you're having a little bit of trouble and you can't remember how to make that pumpkin pie for Thanksgiving, you can give a voice command and the virtual assistant will give you a recipe. You can use them to obtain workout routines, call an Uber. I actually have a patient who used an Uber. This was something we negotiated. The patient was no longer able to drive, but he was very active. He was involved in a lot of community organizations, and the solution was to get an Uber. So you can use the virtual assistants to get an Uber. They can answer questions. It can link to other devices such as Fitbit and even robotic vacuums. You can play games. You can play relaxing nature sounds. You could start a car. Every day it seems like the list of tasks and services is expanding. You can even now use these with certain large banks to do some financial transactions online. They do require internet access, and device-dependent wireless or cellular service. In certain situations, you might need a subscription. You might need a subscription for Pandora, Napster, SiriusXM, or Hulu, Netflix, or Audible if you're going to be streaming music, movies, or even, books. Indoor cameras use motion detection to record and notify of in-home activity. Some models have familiar face recognition. Caregivers can use indoor cameras to monitor home activity when they're away during the night or when a person with memory impairment lives alone. Some systems have features to turn on lights when motion is detected in a room. So this kind of thing is helpful if you have someone who gets up and goes to the bathroom in the night. They can lock doors. They can set home security. They can also adjust lighting and thermostats. I actually have families who are now placing cameras in the home to monitor their family members at night. And if, you know, when the camera detects that there's motion in the house, it sends a message to the family member's smartphone that tells them that their family member is up and roaming around the house, and they can actually access and see the live video to see what their family member is doing. You might notice that this technology is expanding so that there's now overlap of features between indoor cameras and virtual assistants. I mean, people are just really finding more and more ways to connect all these devices together. Some of these indoor cameras will also connect to others in an emergency, adjust lighting and thermostats. We've already talked about that. This is a list of some of the better known indoor cameras. Nest is probably the one that has the largest group of features, but you can go to these websites and you can evaluate the features and the cost and everything yourself. Indoor cameras, they require a Wi-Fi connection, smartphone. We're really getting closer to the fully automated smart home where everything is going to be controlled by voice commands. I mean, some of these even now connect with smart enabled washers, dryers, your furnace, your refrigerator. It's just unbelievable how this is growing. There are also devices out there that will automatically turn off stoves. Most of the devices are for electric stoves. However, iGuard stove just came out this year with one for a gas stove. And this also connects to the Nest smoke detectors. It relies on motion detection so that if you walk away from the stove shuts off after a certain time limit. So you can't walk away and leave food cooking on the stove if you have this iGuard stove device attached. This Caring Home is a organization that just gives a review of all kinds of smart devices, and I just put it there because there are many, many types of automatic turn-off devices and smart devices that could be beneficial in a person's home. And we already talked about the automatic turn-offs use motion detectors and how they're expanding. Trackers. Global positioning systems are devices and software that allow you to create a geofence or a trusted place. You can track people indoors and outdoors. You can track cars. These geofence and trusted places are virtual perimeters, and they're triggered when an individual enters or leaves the designated area. Trackers can come as wearables. They can clip on. They can be part of your clothing. They can be in all types of devices, as we'll see in just a little bit. I'm not sure how many of you are familiar with the global positioning system, but so much of the devices nowadays rely on GPS. I want to just take a couple of slides and review what GPS is and how it's used. GPS is the acronym for the Global Positioning System. The Global Positioning System is a United States-owned utility that provides users with positioning, navigation, and timing services. There's 3 segments to this. It's a space, control, and user. The U.S. Air Force develops, maintains, and operates the space and control segments. And the space segment consists of at least 24 operating satellites, and that's called a constellation, and that transmit a one-way signal giving a current satellite position and time. And this slide shows you an image of what those 24 satellites look like in various orbits rotating around the Earth. Pretty much the entire Earth is covered by the constellation of satellites. The control segment consists of a global network of ground facilities that track the satellites, monitor their transmissions, performs analysis, and sends commands and data to the constellation. So they may send a command, to adjust a satellite's orbit if for some reason the orbit needs to be adjusted. And I just put this up because I want you to realize and look at how far the reach is of the United States GPS utility and where our ground stations are. I mean, we really are like monitoring the entire globe. So how does this work? Well, we're now looking at the user segment. This is basically a GPS receiver equipment, and it uses the transmitted information from the satellites to calculate a user's three-dimensional position and time. And the GPS technology is in everything from cell phones, watches, shipping containers, bulldozers. Farmers are using it. They're in ATMs. And many of these, like tracker devices, they also broadcast a signal. And the signal is sent to a tracking portal system that knows exactly where you are, and then others can receive information from that portal. So for our population, the receivers, you need to have at least 4 satellites for these trackers. The trackers have to obtain data from 4 satellites to obtain a precise location. So if you want to learn more about the GPS system and the complexities and how it's being used, you can go to this gps.gov system, and they've got a wonderful website that gives you all the basic idea on information on GPS systems. So listed on these slides are some trackers with their respective websites for feature details for each device. Some of these are, they're very affordable. They're not that expensive. Trackers are ideal for caregivers who work or are not at home all the time. They can come on in different styles, like you can clip them on somebody's belt loop. They come in watches, so as long as the individual wears the watch. And this Smart Sole even has a tracker in an insole that you could put into somebody's shoe. It's kind of important to see the different options, but you also have to understand the older adult's behavior before you determine what kind of tracker they use. I was talking about with one of my patients' families last week about these trackers, and because she lives out on a farm, her husband is very busy. This is harvest season, and she's home alone quite a bit. And she's never made an attempt to elope, but the nearest person is better than a half mile away. And so we were talking about her behavior, and I was telling him about some of the options for tracker devices. And he said, well, the insole insert would be great because she never takes those shoes off. She wears them. She was wearing a certain pair of tennis shoes, and he said, she never takes these off. She won't wear any other pair of shoes. She wears these from the time she gets up in the morning to the time she goes to bed. So having a tracker insole for her would be good, because then if she, started to go somewhere and wandered out of her geo-fenced perimeter, that would send a signal. Her husband would get a signal to his smartphone, and he would know she's left the house and she's out of the area, and that would give him the opportunity to call for assistance or, himself go to try to reach her. So they really can be beneficial, I think, in the right circumstances. They also have trackers for cars. And you can create geofences for drivers. You can limit where they drive to within, so many miles or blocks of their home. You can monitor the time that they're driving. Car trackers monitor their location, their speed, rapid acceleration, harsh braking, unauthorized hour use, and you can get customizable alerts that come by mobile phone, text, or email. Many of these, like this Moto Safety, was actually developed for teenage drivers, but has been expanded to include senior drivers. And, you know, I often think about our people who suffer from frontal temporal dementia. They tend to be impulsive. And I frequently hear from their family members, oh, they race up on, you know, behind people when they're driving. They don't allow much distance, or they take off in a hurry, or they slam on the brakes. With car trackers, you can monitor that kind of thing. I even have a lady who lived at home, and she was she's not anymore, but at the time was driving and doing quite well, and everybody thought she was fine. But she a couple of times went out in the middle of the night driving around, and that kind of disturbed her family because she was driving in, you know, areas that were probably not too safe. So you can monitor that kind of behavior with car trackers. There are also navigation, tracking, and assistance type services. And these allow you to download directions. You can access an individual who could give you voice directions. These things can unlock a vehicle if you're locked out. They could track a vehicle. They can call for emergency assistance. You could get connected to local services if you have a flat tire or need a tow. And in some cases, that can even slow down the car or shut off the ignition. Remote slowing or shutting down an ignition usually requires involvement of local law enforcement before you can do that. And then again, give voice directions. So I have a lady who used this navigation, tracking, and assistance. She was pretty high functioning, but she was starting to get lost when she was driving, especially going to her yoga class. And she used one of these systems, and it helped her a lot because she actually got a person online who could give her voice directions and say, okay, you need to turn right at the next street. She actually had the OnStar system. OnStar's been out the longest, is probably the best known. It's available on GM vehicles. But there's also, Verizon is offering a plug-in model that you could use on any type of vehicle. We all know Google Maps for their navigation assistance. I'm not sure that there's anybody who isn't aware of Google Maps. There's also the TomTom and Garmin navigation. These two companies are starting to expand their services. I think they want to kind of get into the voice services like OnStar has. There's also now electronic medication dispensers that can give reminders. They can dispense the medication. You can monitor medication adherence. It can be integrated with the medical alert system. These type devices generally do not need internet or phone line because it relies on microcell phone technology. You can do remote programming and monitoring of the medications with the devices. Caregivers can actually log into the account and print reports of medication adherence, or they can get in there and remotely program it. This picture here is just a depiction of one model. This is the MedMinder electronic dispenser. I'm not promoting this product, but I thought they had a really nice image to show you what the options are. So you have the family down in the left-hand side. They can actually program the device. They can view it, you know, if it's been used or not, or if there's still pills that have been left in the container. It also has the capability to let a caregiver, maybe you've got a home health provider who's also logging into the system. The patient is the user at the top. They may get a light that goes off and blinks that tells them, hey, you've got medication that's overdue. They may get an audible alert. They could get a phone call. They could get a text message or an email, depending on their level of functioning. So these are kind of neat devices. Time will tell how effective they are at increasing medication adherence for this population. And again, here are the names and some links to some medication dispensers. We also electronic monitoring for health-related parameters such as blood pressure, weight. You can monitor your EKGs, sleep. So this could be useful. This technology could be useful for people with comorbidities, you know, such as congestive heart failure, atrial fibrillation, insomnia. I know your Fitbit can also monitor your activity and your sleep. So what's new and what's on the horizon? So I want to talk just a few minutes about where technology is going. If you attended the Alzheimer's Association International Conference in Chicago in July of this year, you may have seen the EVA or the PARO therapeutic robots. Companies are developing social robots that interact with people with dementia. Social robots are designed to address isolation, depression, loneliness, agitation, and other behavioral challenges. The EVA can also initiate conversations with people with dementia and can play songs. Paro is a furry harp seal that blinks its eyes. It moves in response to touch. It chirps, it purrs, it wraps its flippers around the handler and cuddles with them. So there have been a small number of studies indicating that those who play with the Paro feel less lonely, more calm, and are happy or happier. Paro has been approved by the FDA. It's a Class 2 neurological therapeutic device, and it costs about $6,400. Researchers are also looking at robot personal aids that monitor people with dementia at night. They monitor their heart rate, their temperature. They may also monitor activity. I mean, all of this is still in the research and development stage. Some of the challenges that are coming up is that speech changes as dementia progresses, and it makes it difficult for the software to interpret what the user is showing. There's also concern that autonomous robots may take away an individual's agency and make decisions for them. There's even some concern that maybe some of these larger models, like if you're familiar with Star Wars, you know, the R2-D2 type robot, these are things that could move around the house, maybe bring you a glass of water or something, that they could fall over and potentially injure an individual. So there's a lot going on out there. Most of it is still in research and development. Virtual reality is another big area. And it's in the early phase of research and development. So what the research has been looking at with virtual reality is like 4 major areas that I found when I did my literature review for this presentation. They're looking at using virtual reality to give other people the experience of dementia. People are thinking this may be valuable for caregivers. If caregivers can put on the VR goggles and experience what it is like to be a person with dementia, then maybe they will be better caregivers for having the experience. There's also a group that is using virtual reality for the patient or the individual with cognitive impairment and helping them to relive prior memories. Happy memories is the goal. So the individual puts on the VR goggles and they may be taken immediately back to a beach scene, you know, if they spent their summers in Florida or whatever, or they had happy memories of being on the beach, VR would transport them back there and they could relive that. The thinking is that this may help people who are agitated or lonely. It may have a calming effect on them. VR is also used for diagnosis. There's some research that shows that navigational skills are impaired early on in cognitive impairment, and using virtual reality to test and evaluate navigational skills may increase accuracy of diagnosis or at least help with early diagnosis. And VR is also being looked at as a way to test driving skills. As you can imagine, there are a lot of ethical issues with the use of technology. It's invasive to put cameras in a person's home or set up a geofence. It's imperative that the older adult understand what devices monitor, how this affects their autonomy, agency, and they need to give informed consent or assent before using this. Any device accessible by the internet is vulnerable to hacking and the consequences of therein. Virtual reality has the potential for creating false memories. We know people with cognitive impairment, sometimes they have dreams they think are real, depending on, their level of impairment. And virtual reality has the potential for creating false memories or altering true memories. And no one really knows what the long-term effect of these devices and technologies are on the older adult. Barriers to the use of technology, well, older adults, they have to have the technology literacy level to be able to use them. They need internet access. They may need more education and training on the devices. They're expensive. They're not really integrated into care at this point. As they become more integrated into care, we'll see an increase in use, and they're rapidly obsolete. Usability, if it's complicated, it's not going to be used much. There's insufficient evidence really for their efficacy. Readability of apps and culturally competent apps are things that developers need to focus on as we go forward with the use of technology. So in conclusion, I just want to say there's significant numbers of older adults with dementia who live alone. They have unique risks. They've got unique unmet care needs. They can continue to live safely home alone if they receive, patient-centered support. And technology can play a role in supporting their autonomy and helping them remain in their homes a little while longer. Thank you very much, and we'll open this up for questions.
Okay, thank you very much, Cindy. That was very informative. I was really happy to hear about some of those new technologies. So let's look back at some of the questions we have. I will say that this presentation is something, the PowerPoint, you can download from this webinar. It should be on your screen as a PowerPoint. Just find the little orange document with a white P on the front that says Living Alone with Dementia. We do have some questions. Let's see. I'm going to go to... You want to try the top one there and work down?
Yeah, do I type?
Let's see. No, we can just talk, but I'll say what the question is. Any information on these clients losing devices like cell phones? Are we talking about, I know there's a lot of time people with dementia might even forget that they have a cell phone, though, so that very well could be part of an issue with getting individuals to try this new technology. I don't know if there's any information or studies on that.
I did not come across any studies on, on the client losing cell phones. I'm sure people will lose cell phones. I misplaced mine. I think there will be, in the future, and there probably already are, apps that help you find your cell phone. If you don't pick it up or turn it within a certain period of time, it'll probably send off a signal, probably audible, so that you can hear it and you'll know to go there. To pick up the phone.
Okay. Someone did want to plug the use of adult day services as it being a helpful support for isolated older adults with dementia. And that is part of the community care programs. Core benefits is adult day service. And I know that we had a symposium earlier this year, and we did have someone present on some of the new technology that's out there. And that's where I had first heard of the baby harp seal, actually. So yes, adult day service is an excellent resource for individuals. I know in the state of Illinois, they're not available in a lot of places, but they are available in, it's kind of sporadic, but it is a good option for people.
It is. It's an important option, and we talked about this last year when we gave this presentation. This year's presentation, though, was more focused on the technology aspect, but that certainly does not demean the importance of adult daycare services.
Okay. And we know that there are a lot of people out there that do not want to go to adult day service, as well as it's not available in all areas of the state. There's a lot of pockets of the state where that is one of the service gaps that does exist.
I think one of the keys is to match up the technology with the level of self-care capability of the individual you're trying to help. So, for some people, the technology may not be that helpful, and traditional services may be of more benefit than technology, and vice versa. So you really have to know the person you're trying to help.
Looks like we have a question about, are there any of these technology devices covered under Medicare, Medicaid?
Not that I'm aware of.
Yeah, that's probably, a lot of this technology is very new and in its infancy.
And it's unproven.
Yeah, and unproven. That's another thing, especially with Medicare or Medicaid coverage. A lot of tried and true technology that's out there. Sometimes if it's a free technology, you'd have to see if it actually works with the person, like Cindy said. You'd have to gauge that based on their skill level. Okay, we did have a question for continuing education. Yes, I will send that information out probably next week. And again, if you cannot download a copy of this webinar, you can request a copy. It will be in a follow-up email that will probably come around 4:30 today. Any other questions for Cindy? Okay. All right. Well, thank you all very much. I will let you know that in the follow-up email, there will be a chance to retake that survey. If you were able to participate in that Survey Monkey that I had sent out prior to the webinar, we would love to have you retake it and see if you can improve your score. And we thank Cindy very much. The PowerPoint does have some references. All of the references within the presentation are there, and you can click on the links if you would like some additional information. We will also have a recording of this available for those who could not participate today, and we should have that ready in a link probably next week. Thank you again, Cindy, for coming out.
Thank you.
And we appreciate your time. And have a good afternoon and a good weekend, everyone. Thank you.